everyone. Today I'm going to talk about cases of cardiomyopathies that might carry differential diagnosis or different differential diagnosis, and sometimes it's difficult from MRI only to see the differential or to detect one differential diagnosis. As we mentioned before, that the approach to cardiomyopathies is, of course, after review of the clinical history and viewing the images, you would try to put the case in one of the lines or the pathways, whether there is hypertrophy or there is dilatation, so whether it's hypertrophic cardiomyopathy and its differential diagnosis, or is it dilated cardiomyopathy and its differential diagnosis. For instance, this case, as you may see here, the left ventricle is dilated, so the indexed left ventricular volume was 120, and on MRI still we could measure the diameters in order to correlate well with the echoes. So it's around 7 centimeters, and usually we measure this diameter on a cine image basal cut where there is no partial volume from the LVOT. For example, we cannot measure it in this slice, but usually we could measure it in this slice, for example, again. So we could measure the diameter of the left ventricle from the superior insertion point or the inferior insertion point to the opposite wall, which would correlate with the echo measurements and the index volume on MRI. And also, as you may see here, so in hypertensive cardiomyopathies, yes, the left ventricle might be dilated with reduced function, but usually the wall is kind of symmetrically hypertrophied, or the wall thickness at least would be preserved. But in cases of other differential diagnosis of cardiomyopathies, for example, in this case, you may see that the wall thickness is thinned out diffusely, so it's not in one segment or not in one territorial, but diffusely, that the left ventricular wall thickness is thinned out. So with the findings so far that we have, dilated cardiomyopathy, dilated left ventricle, reduced function with a thinned out wall thickness. The history was 45 years old male with a rare syndrome that causes early emphysema, changes in the lungs. Recently, there was an echo showed left ventricular systolic dysfunction, and the patient got a coronary angiogram that was completely normal. Therefore, the patient was sent for MRI for detection of cardiomyopathy or underlying cardiomyopathy. Usually, the pattern of late enhancement would help in order to detect the type of the cardiomyopathy that we are viewing or that we see on MRI. As we previously mentioned and showed, myocarditis late enhancement. For example, in this case, let's go, for example, in this case, this is a short axis view, late enhancement, and usually the late enhancement is around 7 to 10 minutes, sometimes 15 minutes after giving the late gadolinium or after giving the gadolinium intravenous. As you may see here, there is diffuse contrast enhancement in the subepicardial layer along the lateral wall, and there is late enhancement mid-wall in the septum. All those patterns or both patterns are non-ischemic. An ischemic cause would present in late enhancement as subendocardial or subendocardial to transmural, but the subendocardium is the most vascular part. Therefore, whenever there is a coronary artery disease or coronary artery event, the subendocardium is first to be affected. So it's impossible to see a subepi before subendo in an ischemic event, which means that this case is not an ischemic cardiomyopathy. So we need to think about differential diagnosis of cases where there is subepi and mid-wall all around or diffuse in this way. The differential diagnosis in this case, first, maybe myocarditis, which was severe myocarditis. Second, sarcoidosis, but let me show you the axial images. And there was no lymph nodes, and there was no indication that there is a kind of sarcoid, although in 5 to 10% of the cases sarcoid could be affecting the heart only without affecting the lungs. Back again to the late enhancement. So for example, this is a 3-chamber view, so we could see the mid-wall, the sub-epi. So still we have myocarditis in the differential diagnosis, and sarcoidosis, or one of the left ventricular arrhythmogenic cardiomyopathies. So those would be the 3 possibilities in this case, and probably we would recommend to correlate clinically, and if it turned out to be one of the arrhythmogenic left ventricular cardiomyopathies, then we need to recommend in the MRI family consultation and family screening to other family members. Thank you.